Dentistry and General Radio Network presents
the Independent Dental Practice Podcast with Dr. Sonny Spera. In this episode,
welcome to the Independent Dental Practice Podcast. Dr. Sonny Spera. Today, my guest, Dr. Ed Feinberg. We are going to talk about implants versus crown and bridge, and he has a very strong opinion because of his training, his dad's training, and he has, between the two of them, have 70 years of experience in crown and bridge. And you're going to hear some things you probably don't hear or see too often, especially in the social media areas. Our conversation is very good. Hopefully everybody will pick up some nuggets from it, and maybe you'll disagree. You can reach Dr. Feinberg at edfbergdmd@gmail. I have it all on the show notes. If you like it, click like, subscribe, share it with your friends, please. If you don't like it, well, hell, share it with me. Call me, text me, email me, sonnyspera@gmail.com. Or we now have the Independent Dental Practice Podcast at gmail.com, or 607-624-2962 is my personal cell. You want to hit me up, I'd appreciate it. Thanks a lot, everybody. Enjoy the show.
the truth about implants and bridges, lessons from 70 years of dentistry. Dr. Sonny Spera interviews Dr. Ed Feinberg.
Welcome to the Independent Dental Practice Podcast. Dr. Sonny Spera. Today I have a guest that I have known about and talked to and consider him a good friend. It's Dr. Ed Feinberg, but let me give you some background. He is a 1974 magna cum laude undergrad of Tufts, and he loved it so much he stayed there, went to dental school at Tufts, graduated in 77, did a residency and hospital internship at Bronx, Lebanon, and then went in private practice with his father in Scarsdale, New York. Continued on instructing and writing, and his resume is 17 pages. Let me give you a little background. Dr. Feinberg works with dentists who want to improve their crown and bridge work skills so that they can deliver better treatment outcomes for their patients. He's a graduate of Tufts and has practiced in Scarsdale and New York for more than 40 years. He is now practicing in Arizona. He is a successor to a unique tradition of restorative dentistry. He was trained by a master pioneer in full coverage restorative, Dr. Elliot Feinberg. The techniques that he and his dad have documented with more than 100,000 photographs taken for the past 70 years. All right. He is currently the director of Onward, an online teaching organization for the full coverage dentistry. www.theonwardprogram.com. And to date, he's created more than 35 online courses for the site. It also has an extensive library of downloadable materials and monthly blog. Welcome, Ed. How you doing, man?
I'm doing great.
Hope I did your intro some justice.
Yes, it was very nice. Thank you.
Whenever
I hear intros like that, I say to myself, I did all that.
Yeah, that's you, man. It's not me. Our topic today, we're going to talk about implants versus crown and bridge. And I know anybody that's been on Facebook or any of these dental sites have seen the touting of implants as the panacea to cure all ails. This tooth needs titanium. I see that comment multiple times. And I place implants myself, so I'm not degrading implants, but I don't feel that they are a be-all, end-all solution. So knowing your vast experience and background in crown and bridge, I thought, hey, let's chat on this topic. So why don't we get started? How long have you been aware or have worked with implants in your own practice?
Well, we started doing implants in the early 80s when they first came to this country.
Mhm.
I really know quite a bit about implants, and I know they are not lifetime. And I have had the patient where the implants only lasted 20 years, and that was it. When they first came to this country, they were all being done the way Dr. Brannemark said to do them. He was a true scientist and somebody I really admired because he did 20 years of studies before he ever came to this country and told people how to do implants. And he outlined basic principles for success. And you knew that if you followed what he said, you could have the same success that he had, which was in the 85 to 95% success rate. And I have his book, a lot of things that I see people doing with implants, specifically all on four, are something that Brannemark avoided altogether and had good success because the implants weren't overloaded the way they are being overloaded today. I think Carl Misch outlined very distinctly and basic engineering principles that are necessary, that the science of implants really must conform to basic principles of biomechanics. And he outlined it very clear. And Brannemark followed that. And they are being systematically violated with implant cases. And in engineering, you can't violate basic principles. If you overload the foundation, you are going to have an engineering failure, even if the implants take. And I think more people need to be aware of that. And that's also true for crown and bridge on natural teeth. It's exactly the same thing. So what I have done for my entire career is engineering, basic principles of engineering. And I like to, when I give courses, I like to compare famous engineering disasters to their counterparts in the mouth because the same things happen, except in the engineering world, people get killed. And in the dental world, we might not lose the case in the implants or the natural teeth, but nobody really dies. And I guess that's the difference.
So let's talk just a very simple case. Okay. And let's talk one, it's in the upper, and we'll talk one in the lower. Same scenario. Patient in the upper is missing tooth 13. You can place an implant, you can do a bridge. Patient is on the lower, we'll say is missing number 19. Same holds true. You can make a bridge from 18 to 20, or you could do a bridge in the 19 area. So talk about what you see are some of the differences. And just we'll talk about the upper first. What are some of the distinct differences that you at least have that discussion with your patients? What is it?
I believe that implants should be a last resort, except in certain circumstances. So if you had a perfect mouth where the teeth were virginal and there was no periodontal bone loss, that's a perfect place for an implant because you don't have to touch the adjacent teeth with a drill. But if you look carefully, you will see the teeth around the space either have periodontal bone loss, big fillings, crowns, are going to need crowns. It is not a virginal mouth. If you know how to do good crown and bridge, you can do something good for that whole area. Whereas an implant only fills a hole or a space and does nothing for the teeth around it. That is a very piecemeal approach to dentistry. And if you know how to do good crown and bridge, you can compensate for periodontal bone loss to prevent future bone loss. You can change the architecture to put less stress on the bone and the roots. And you can tie them together so that they help each other out rather than each tooth having to carry all the forces by itself. And sometimes that's enough. That's the end of the periodontal disease. I have 70 years of documented evidence that a big part of periodontal disease is not just bacteria, but forces being acted on the teeth themselves. And in 1964, Thomas Ford described this as force-induced degeneration. So an implant would do nothing for the teeth around it, and that patient would continually have problems, and their problems are never solved. So an overall approach really looks at the whole mouth as a whole, rather than a piecemeal approach which concentrates on filling a hole or a space. Now, most people are being trained with crown and bridge to think of crown and bridge as simple tooth coverings and nothing more. And that's not true. You are changing the architecture and minimizing forces. So you have to be very good at being diligent about details. You can't make the teeth oversized, which is what's happening in every lab. If you took an Iwanson gauge and you measured every crown, you'd be horrified. Because if you know you can only take off 1 millimeter to 1.5 millimeters of tooth structure on a vital tooth, you certainly don't want to put back more than that. I try to put back less, so I put less stress on the supporting structures. That means you have to have a very diligent approach to doing crown and bridge. Everything has to be exact. You have to have a step-by-step protocol.
So walk through this. What would be some of the things that would be in your mind? Like, what are your checkpoints when you're evaluating? I'm going to stick with that same case, that upper area, doing a bridge. You already mentioned the restorative part. Are they restored? Are the teeth virgin? Periodontally, is it pristine? Okay. But let's just say you're evaluating it to do a bridge. What are some of the factors that for you are, I don't know, I'll call red lights or yellow lights, but what are some factors that stand out?
I have everything in my armamentarium. I can do good bridge work. I can do good implants. I can do good precision attachment case, which nobody knows anything about. and was invented in 1906 and has a great track record, which is so sad. And I see all the people having troubles with crown and bridge techniques. These problems were solved in the 1930s. A lot of people don't have confidence in crown and bridge, and there are a lot of people who can do very good implants. And they're pretty much one-trick ponies because that's all they know how to do. But that isn't the answer to every problem. In fact, most of the time, it's not the answer at all. And you
Okay,
have
so
to be able to
but as you're
think.
looking at it, as you're looking at and evaluating that, what are some things that you're evaluating? What are you looking at for the occlusion? What are you looking at for canine? What are some of the factors that are going through your steps
Okay,
of designing? Let's just say you're going to put a bridge on. In your mind, you're saying, okay, these are the things I want to make sure I check off. What are some things?
well, when I first get a patient, the first thing I do is I take a full series of x-rays and I take upper and lower study models
Okay.
and I sit down and analyze everything because you can't just look at one little area and not take into account the whole mouth. So if you are going to do anything, you want to make sure that you're going to solve all the problems. One of the problems is growth and development, where the teeth don't come into place in harmony with the musculature. Sometimes there are symptoms, which are the tip-off that something isn't right, but sometimes there are no symptoms. So if you look and see the bone in the roots, because that's what I'm mostly interested, and if you have good long roots and good bone, that is a very good candidate for crown and bridge work. And maybe implants too, but maybe not, because sometimes the sinuses are in the way, the number 13 that you gave, and maybe that is not a good choice. And then I also look and put the models together and I look at the plane of occlusion. I look at whether the midlines of the jaws come together or not. And these are tip-offs that something isn't right and that should be checked out. So now in the 1960s, this guy, Abraham Berliner, which nobody knows anything about, was treating these patients with appliance therapy. And I use appliances in a diagnostic way that date all the way back to the 1960s. And that's what I got from my dad. And if the musculature is not in harmony with the way the teeth come together, appliance therapy will very often identify that. So it's a simple Hawley bite plate that allows the jaw to go wherever it wants to. When you bring your teeth together, your teeth send a message to the brain telling the jaw where to go. So the appliance interrupts that message so that the muscles tell the jaw where to go. And the patient has to eat with it, sleep with it, and when they take their appliance out to brush their teeth, they cannot bring their teeth together. And after a couple of weeks, you can check to see where the teeth want to come together. And you could take a wax bite and mount the models and see what would you have to do in order to correct this problem. Now, a lot of times the problem is not that at all, and you do not know what's going to happen, and you can't have preconceived ideas. You have to let nature do it. So sometimes the jaws are in perfect position, and it's simple to make bridge work for that one little area. So now you mentioned number 13, and I will give you an actual patient case that I had, and I show this when I give lectures. I think it's in one of my courses online. So I had a young girl, and she had number 13 was a deciduous tooth that was on its way out.
Gotcha. Okay.
And she was very scared, and the sinuses, there was absolutely no bone above the sinus for an implant. And she would have had to have quite a bit of grafting in order to be able to place an implant. And she didn't want that. Patients, I believe, should have choices. So what I did for her, because she was young, I prepared one tooth, the back molar, and I made a 2-unit bridge with the back molar carrying the entire thing. And nobody could tell that the tooth was missing at all. And one day she may have to extend that to other teeth. Dentistry is not lifetime. There's a point at which dentistry needs to be done over, and that point is different for everybody. Some people, they can go like 40 years because the changes are minimal and gradual. They don't have to replace the dentistry. But others have to replace it after 10 to 15 years, and it can be a very tough call as to when you should actually step in there and do that. So she's young, and because she's young, she can get away with a lot. And younger patients can tolerate a lot more. As you get older, the body can't tolerate certain things, and that's when you start to see breakdown and troubles. And that's why it's so important to make dentistry that solves the problems, minimizes the forces, because in spite of all of those problems, and problems also like heart disease, diabetes, and cancer, dentistry can hold up. That you would not expect that, but that's what I can show. And then if you can show that, then you know you're doing something right.
Okay, so
And
now let
that's
me
what,
ask you. Let me ask you to this point now. There's multiple materials, right? So there's all gold. We'll go old school, all gold. Then there's porcelain fused to metal. Then there's the all porcelains. What are some of your thoughts now on your material of choice for that
the
bridge?
best material ever devised for dentistry is gold, hands down. Everyone who knows that, who's worked with gold or who has seen how gold holds up in the mouth, knows that. So that is the best material. But of course, people do not want to show gold. So the next best material is porcelain to metal. All porcelain restorations are what you call butt joint restorations. And the problem with butt joint restorations is known since the 1930s, is that they can never be sealed. Bacteria are microns, and you cannot see at that level what's sealed and what's not sealed. And people have an unrealistic idea of expecting the bonding crap to seal everything up, and that's not really realistic. So when I make crowns, I make them on the model of the mason jar cover, which is the best known thing ever devised for preserving. So I almost never get decay under my crowns. And I also get tremendous retention because I take advantage of all of the tooth structure below the gingiva. And most people do not go down that far. And that's why they're having troubles with crowns falling out and decay under their crowns. These problems were solved in the 1930s. My dad's teacher didn't have these problems. That's sad when you think about it. And I think part of the problem is that there are a lot of misconceptions and techniques that are being taught in dental schools that are incorrect. And everyone just marches in lockstep and believes it. Now, the latest new material, zirconia,
Mhm.
that came from nuclear power plants, and that's where it belongs. It's not a good material for dentistry, and the only reason why it's being used is because it's cheap and white. One of the things why is that they're butt joint restorations. Again, I just mentioned that I don't believe in butt joint restoration, so that's one strike against it. The next thing is that you can't connect them. So if you want to splint the teeth together, you can't do this with zirconia. And then the third thing is that this is so hard a material. It's very important to recognize that dentistry is not lifetime, and you will have to take these things off at some time in the patient's life to make new dentistry. And you could absolutely damage the teeth underneath trying to get one of these things off. So I don't think it's a good material for dentistry. And I don't think any science was done on it at all. And everybody's using it without any evidence whatsoever. And they're using them just as single restorations. Again, another piecemeal approach to dentistry, because one of the things I like to teach is how splinting can avoid problems. And I splint a lot of teeth preventatively in order to distribute the load on the foundation, especially if there's been periodontal bone loss. My dad has that statement right in his book about splinting. And so this goes way back, and people forgot about that. And that's really surprising to me. We're talking about basic principles of engineering, and a lot of what's being done is absolutely violating the basic principles.
All right, so let's take it. So now we've talked the upper. Let's go to that lower example. What's the difference between the lower and the upper, first of all, for you?
The bone is usually better, it's denser, but that doesn't mean that you can still place implants.
I was going to ask you, does that make implants a little more appealing then at that point?
It really depends, okay? It depends on the situation. So, for example, you're missing, didn't you mention what number?
19
What,
is the tooth missing.
19? Okay. If
We're going
you have a
above 18.
virginal mouth and you have good bone and you want to place an implant there, that's a perfect place for an implant. Nobody says no, but that's not the norm. You'll have something with the teeth around it, and that changes everything. I think bridge work is a much better choice. I think implants should be a last resort otherwise. That's my opinion. So a lot of times
But in
people,
your mind, when you're evaluating, in this scenario, you evaluate the upper and you evaluate the lower. You talked about the bone being denser. Are there any other factors in your mind, let's say a molar versus a premolar as being the pontic? Are there other factors in your mind that are important in making these decisions now?
yes, it's the teeth around the space that are most important. What is the status of them? Is there periodontal bone loss? Are there big fillings? I think that bridge work is a much better choice in those conditions. And you can cantilever, let's say you don't want to touch the cuspid because that is the hardest teeth to prepare, that what you're putting back isn't bigger than what was there before and could be an eyesore. So I've made many cases where I cantilever the bicuspid. from the two molars behind it. And that can easily carry the load of that cantilever and nobody could tell. And that the patients should have choices too. I really don't think there's one size fits all.
Right.
You can't make blanket statements about that. But if I see patients with where the teeth are broken down, I would try to talk them into doing bridge work because they're going to need crowns anyway. Why not do it now and then they're done? And most people don't go to the dentist to have implants. They go to have their teeth saved. That is what they really want. Although there are certain exceptions for that. I could tell you some stories, and I think those people are going to be sorry in the long run, especially with this all on four stuff.
Okay. So let's go back to the basic discussion then. Implant versus crown and bridge. What are some other factors that need to be looked at when you're deciding implant and bridge?
Sometimes you can have patients with a missing second molar, and a lot of people say, oh, we want to put an implant in there. If the two teeth above the space have crowns on them, they can be tied together. They're really only worried about super eruption, and that's it. And I think if you would stay away from that area that could affect the nerve, you'd be better off and not put anything in there.
So let's say a person's missing 18. The solution would be if there's crowns on 14 and 15 to splint those two so there's no super eruption.
That's right. And that's all you have to do. And that's fine. A patient can function and be comfortable and no problem. I have that in my mouth. Okay.
No, but I'm saying, so that's to keep, that's to maintain the upper, and you're still not replacing the lower two? Or are you cantilevering a bridge back to replace it?
No, I'd leave it alone. You don't have to do that because the one thing you were worried about is super eruption. And that's all. That's all you're worried about. You tie the opposing two teeth together, especially if they're big fillings and going to need crowns anyway. Or I would tell the patient, listen, if you don't want to put an implant in that area, we'll watch this carefully. Then we may have to do some crown and bridge on the opposing arch. And that's fine too, because not every time patients have super eruption, that doesn't always happen. And if it doesn't happen, then they don't have to do anything. So
how about the length of time the tooth has been missing, right? So let's say in the same example, the tooth, we'll go back to the upper, 13 has been missing for several years. And now you've seen the result of some changes occurring on the opposing arch with the curve of C and
that's a really good question.
So talk about those things now.
Okay, so that is a really good question. So what happens when you have missing teeth is that the teeth around the space shift and the teeth opposite the space erupt into the space, and they will start taking forces in abnormal directions that God never intended. And if you don't correct the plane of occlusion and change the architecture, especially of the tooth that's super erupted, then you're just going to have problems with whatever you put in that space, man-made materials. So now I have this case where somebody stuck an implant and they didn't, in a lower missing bicuspid, and they didn't adjust the plane of occlusion of the upper. Sometimes it means doing crown and bridge in order to do that. So the forces that were acting on this implant were enough to shear the implant below the bone level. I never saw anything like it. And that's the kind of forces that could be generated in the mouth. So one of the ways of distributing the forces is to have an even plane of occlusion. So sometimes you can adjust the cusps a little bit of the teeth in order to get a good plane of occlusion. But sometimes you have to do crown and bridge. Sometimes one crown is all you need in order to raise the tooth back into the plane. Sometimes you have to do more than that. And if I'm going to change the plane of occlusion, and I'm doing one arch at a time, I'm not going to make it to the deformities that are on the opposing arch. I'm going to make it to an ideal plane of occlusion so that when I come back later and do the opposing arch, I'm going to end up with an ideal plane of occlusion and an ideal occlusion altogether, which is what I'm trying to do. So that's an overall approach to patient care. Instead of filling a hole or a space, making a quick buck and not worrying about what happens to the patient down the road. And that's how I was trained, to look at things that way. And I don't see too many people being trained that way. And they're really looking to make a quick dollar, make it easy, stick something in and not worry about what happens down the road. What does it for me is when I get to see my patient come in year after year for their hygiene visits, and I get to watch the work that I did last in health year after year after year. And I have some patients that I did dentistry and it's in the mouth 40 years. And that you did something good for that patient, and they know it too, because they have friends and relatives who are having lots of problems and they are not. And that's the difference. So I want to teach this because this is what was given to me. And I don't find too many people interested in learning how to do this. And that's very upsetting.
Okay, so let's go right back to that same example. We'll do the lower now. The upper arch is intact. The lower arches, they're missing 19. Okay. And there are some obvious wear facets, the opposite side. There's some maybe a little collapse in VDO. What's the conversation where the person's like, Doc, I just want to put this one tooth in? Like you said, I just want to fix this over on this side. What's your conversation to try to get them to understand the whole mouth as opposed to just that one segment?
I sit down with the patient and explain that when I get, as I mentioned earlier, I take full a series of x-rays and models, and I sit down and analyze and everything. And I point out the wear facets and the problems. Maybe the midlines of the jaws don't line up. And I talk to them about piecemeal and about doing something definitive that corrects all the problems so that they get to hold on to their teeth. And ultimately, the patients have a choice to do whatever they want. Sometimes all they can do is piecemeal at this time, and you have to be kind to people. As long as they understand, and you let them know that one day we'll have to do this, that, or the other thing, that's fine. There's a place for piecemeal. I'm not saying no, that every single patient should have definitive treatment and nothing else. That's why you need a lot of different things in your armamentarium so you could really help people. Not every person is a candidate for sophisticated dentistry, not just financially, but for other reasons. Then you have to come up with something to help that patient. But if I can, and even if I'm doing one tooth, I'm going to adjust the opposing arch even a little bit if I can to make a better plane of occlusion without doing dentistry. I can at least do that because that's how I think. And I'll explain that to the patient. So
Okay.
it really
So do
depends
you
on
ever
the situation and the patient.
do you ever use orthodontic, Invisalign, or conventional ortho prior?
That's a good question too, because you see, I'm not an orthodontist.
Well, you
I
understand
want
the
to know.
occlusion, right?
Yes, I want to know. Very often, I would take models and X-rays to my orthodontist buddy, and I would sit down. We usually go out to lunch. What can you do for this patient? What can you do for that patient? That's part of my presentation to the patient. And if they want to do it, then I send them to the orthodontist right off the bat. I've had some patients where they only need orthodontics, and crown and bridge or implants is not something that they need, and
Okay.
they're really belong in an orthodontic office. I have some patients where they need a combination of ortho and
Right.
crown and bridge work, or ortho and implants. So I have one. Sometimes and things go wrong too. I had one patient who had ortho. Now she's ready to go to college, and the orthodontist didn't allow for implants to be placed in the sites where they were congenitally missing lateral incisors, which is a perfect place for implants. So then your only recourse is to do crown and bridge. So I prepared the eye teeth and cantilevered the laterals off of them because I couldn't do implants. So you have to have more than one thing in your armamentarium so that you can pick and choose what's really best for each patient. You can't say, I'm only going to do implants, because a lot of times that's not the right choice or may not even be a choice. You can't say, I only do definitive treatment and they have to go through years of ortho. You can't do that. You have to be kind and help people. So I'm there to help them. So I want them to know what the pros and cons are, and then help them make the choice that's best for them. I don't like to push people into anything. And
Okay.
I
I got
think
the most important question I've asked you of the night. Most important. Ready?
I'm ready.
When you go to lunch with the orthodontist to review the cases, who pays for lunch?
I'm happy to pay for it, but a lot of times the orthodontist pays for it because
That's good to
I'm going
hear.
to send him the patient, and he
That's
knows
good.
it
That's
because
good.
I
I'm
don't do
glad to hear that.
ortho.
That's good to hear. Let's share the wealth, baby. All right. That's great. All
But
right.
also, too, I
Yeah.
had Invisalign, and I'm actually working with the wife of an orthodontist. She's a general dentist, and he's an orthodontist.
Hmm.
So all my teeth shifted after so many years. So he did the aligners for me. And it's so much easier to keep these teeth clean. So now when I see patients with crowded lower incisors, I try to talk them into doing the aligners because I think it's much better, and it's amazing what a difference it makes.
Now I got to ask you this because this is a big selling point with a lot of aligner companies. Any abfractions or what do they call it? Non-carious cervical lesion, NCCL. Okay. What's your thoughts when you see a patient that has a lot of that?
Oh, I think it's an occlusal problem without question. And I have those
Primarily or
patients.
exclusively?
I would say mostly exclusively because I can show you cases that I did where I changed the architecture of the teeth. And you can't do this with fillings or bonding or veneers. It has to be crowns. It's the only thing that you can control the complete architecture and change it. I try to make the teeth smaller. I make it to ideal plane of occlusion, no steep cusps. I get rid of all the things that cause the problem in the first place. And that's usually the end of the abfractions. That's usually the end of it.
So do you think there's a group function versus canine function? Talk a little bit about that component of the occlusion.
I like canine guidance. I don't like group function if I can avoid it. That's what I like. I think that those patients, their cases hold up better. But
Do you think the group
everybody's
function
different.
is a problem with these abfractions? Do you think that's one of the
It
major
might
problems?
be. I'm not going to say I'm an expert in this. All I can tell you is that I have gotten rid of it by giving ideal architecture. And when you see teeth like that, there's usually recession, and you could see that the architecture is incorrect of those teeth. You could see
How
right off
about
the
the
bat.
crossbite? What do you do? What do you do? Same scenario where the teeth are missing, but there's a crossbite.
First, I would
Because
check
I
that out with
find,
appliance therapy to see if the
because
jaw's in the right position.
I do want to admit when I'm working on teeth that are in crossbite, like we're doing a single crown on something, those are some of the trickiest, what looks simple, some of the trickiest things because the rules are different. So what's your thoughts on that?
I look at the whole overall thing and what is causing the crossbite. I'm going to examine those models carefully, and I may put the patient on a diagnostic appliance to check the jaw position first before I would do anything. And then we'll see from there. I don't have the answer right always at the top of my head.
Mhm.
And as a dentist, you should never feel pressured to give an answer because the patient is there and they're scheduled on the day sheet. You don't have to give an answer. I sometimes need time to think about it. I get opinions from other people who might know more than me.
Mhm.
I don't know everything. I don't pretend to. But I'm interested and I want to know. And so I might ask questions. I bring the models and the x-rays. And I see too many dentists, especially when you look in dental social media groups, they don't put up full series of x-rays at all, little bits of x-rays, and they're asking people what they should do when you have no idea what's going on in the rest of the mouth. And that's how could you make a decision? What you do on one side of the mouth affects the other side. So now I can tell you a story about one of my patients where I didn't do that. I didn't know. I thought, oh, we're going to do implants on the other side. They were most of the teeth were missing except for one back molar and the eye tooth on that side. And I did the two crowns on the other side and the posterior. And then I found out that he can't have implants. What do you do now? I made him a precision attachment case, and I took the porcelain off the back molar on the other side, and I put the crown, an overlay crown with the attachment in it, and I extended the bar all the way around to the other side, and that's how I got out from under an attachment in the eye tooth and also the back molar, and that's how I got around that because I know how to make a good precision attachment case, specifically the double tilt precision attachment case, which is a very good solution to a lot of restorative problems. Fixed bridge work is not the answer to everything. And fixed bridge work on implants sometimes can't be done. What do you do then? See, because I know how to make the double tilt precision attachment case, I've made a lot of cases where I put three implants in the front and made a fixed bridge and a posterior precision attachment case. And I stayed away from all of the sinus lifts and all of that stuff. And you think you'd be surprised what patients choose when they're given choices. So if you have all these choices in your armamentarium, you can pick and choose what's best for each patient. It's not only the money, it's also what you have to go through. So I try to figure out what would be the least the patient has to go through and how could you correct everything. And we're all biased against removables, but people don't know anything about the double tilt precision attachment case, which I wrote a textbook on and was invented in 1906 and works on the worst teeth you ever saw. I could show miracles that were done using that case. That's a good treatment option, really, especially for people who can't have implants and you have to work with what's there. And sometimes they can't have them posteriorly. But if I could put three good ones in the front, that's all I need. And I can make a great case. Those are the best cases.
All right. This is really informative. So with that, talk a little bit about how people can get some of the things that you're teaching. Where are you located at? Where's your teaching
Everything
website?
is Almost everything is on the teaching website. www.theonwardprogram.com. I also have 2 books on Amazon. One is the textbook on the double tilt precision attachment case, and it's for natural teeth and implants. And the other is a book of essays, which are the blogs on my website. And the blogs are on different issues in dentistry that I see going on and my take on it. And I'm very vocal about what I believe in. And sometimes that doesn't endear me to people, but I tell the truth the way I see it, because I've had the ability to see where dentistry came from, and I could see where it's going. And I don't like the direction of things that it's going in. I think a lot of it's wrong. They can't even do, with all this fancy technology, what my dad did in the 50s and 60s. Think about that. That's pretty scary. And I want to teach this. I don't want to see this all go by the wayside, because you could really help people. I also have the ability to save teeth flush with the gingiva without posts, without buildups, without fancy orthodontic extrusion, and without extensive periodontal crown lengthening. I have boxes full of teeth like that I did, that you don't need any of that for retention. And I don't consider those teeth any different from any other teeth. And I teach that on the website as well. I can help people even temporarily, because I make my temporaries with copper bands or aluminum bands. And that enables me to save those teeth without patients walking around with no teeth, and they fit like permanents. And they also seal the teeth against decay like permanents do, because they're based on the same mason jar cover concept that I alluded to earlier. If you have a patient who, let's say, can't do crowns and bridges now, or they're going away and they're not going to be back for a while, I can make them a great temporary and not worry about it and know that tooth is going to be in great shape when they're ready to do the work. I help a lot of people like that. And those are the people that are being turned away. And I think that's unfair. As dentists, we should be helping those people who are not ready to do sophisticated dentistry or not candidates to do sophisticated dentistry. So I have options for those people as well. And I get just as much pleasure of helping those people as I do putting in an amazingly great case. Are
you a member of the Giraffe Club?
No, what is that?
Oh, that's the docs. They stick their neck out, and they're not afraid to speak up for what they believe in. You sound like a perfect candidate for it.
I am the giraffe. I think that's a good analogy. I'm not afraid to stick my neck out, but I have 70 years of documented cases. So very often when a patient comes in, I've seen that case before, and I'm not afraid to show them that case and how it held up. This is like your case, Mrs. Jones, and look how it held up 35 years in the mouth. And that's what I want for you, and I think you have the same foundation that I could do it.
Perfect.
It's perfect, right?
Can't be any better than that. So I want to thank you for spending some time with me and sharing many of the insights. I think it was a lot of fun. And I'm not going to say contrary, but it's not in the popular mainstream dental media, what we talked about. Everything has been emphasis on titanium. So,
well, think about why that is. Okay, several reasons why. One is, unfortunately, students are getting out of school with these huge debts, and they are forced to think about how they're going to pay those debts back before they can even concentrate on building their knowledge and skills, which is what they should be doing right away when they get out of school. And so what's easier and more lucrative is putting implants in, because they can learn how to do that quickly, and then they can make lots of money that way. And another reason is, who is funding the continuing education? The implant manufacturers. What do you think they want? What kind of speakers do you think they want to see in the curriculums of major meetings and dental schools? Think about that. We are being manipulated that way. And they swore they would never let that happen when I started in practice. And that's exactly what happened.
Let's not go there, because now I'm going to go on my rant about the intrusion of insurance companies in the education process as far as that goes, as well as corporations basically starting their own dental schools and everything else. So
maybe we could do another podcast. And
we have bastardized the whole education process.
I have lots of thoughts about that too.
Yeah, so do I. So thanks for your time, Ed. Appreciate it. You enjoy the sunny weather out in beautiful Scottsdale. I'm in Binghamton, New York. I'll be wearing sweaters for a little while longer. All right.
Thank you so much. I really enjoyed being a guest on your podcast.
Thank you. It was great. Appreciate it.
This has been a production of Dentistry in General Radio Network. Visit our website, dentistryingeneral.com, to join engaging clinical and business conversations, explore our dental podcasts, and stay updated on our upcoming live events.